Our first speaker, first of all, we're doing a benign section this afternoon, and my first speaker I have a pleasure to present is Sarah Grahn. She was one of our trainees a few years ago. It's been very interesting to see her grow into a mature woman, and she's going to present Bowel Prep Resurgence, Vintage Trend or Data Driven. It's interesting for some of us with gray hair here, we never stopped doing bowel preps. So we'll see what she has to say about the people that did and whether it's coming back. Sarah?
Oh, just one quick thing. There are some interesting pictures since I'm doing data and vintage. There's some photos in here that have nothing to do with bowel prep, but were interesting progression of computers throughout this time frame that we're going to talk about. And mostly this is sort of like a historical walkthrough of what's gone on with bowel preps with some suggestions. So in this talk, we'll just basically talk about the pendulum swing that's gone through with bowel prep and some data behind that and some interesting things that I learned along the way that have certainly impacted my thoughts on this. So in the 1970s, Nichols and Contaminated demonstrated that oral antibiotics likely reduced the rate of infections after colon surgery. At that time, the antibiotic choices were somewhat limited, and what they had was not effective against all the flora within the colon, but they showed that through mechanical bowel preparation they were able to reduce the fecal mass, but it actually did little to reduce the amount of bacteria in the colon and the spectrum of and the diverse flora there. They demonstrated that the combination of neomycin and erythromycin orally the day before surgery was able to reduce the fecal aerobic and anaerobic flora where other agents didn't. They did a small series, 11 on each side, where they compared mechanical bowel preparation with or without the neomycin and erythromycin, and they had a rather remarkable drop from 30 to 0 in those that received that, prompting the use of oral antibiotics along with mechanical bowel preparation at that time. They did these studies, and they were taking samples from the colon during laparoscopic cholecystectomies, so non-colon surgeries, and just were sampling and really investigating what was going on in the colon, and found that the luminal concentration of erythromycin was increased with the bowel preparation, further supporting their recommendations for that pre-surgery treatment. There was numerous Veterans Affairs studies during that time frame, and they showed the septic complications were reduced with the oral antibiotics from 43% down to 9%, which really, that 9% is better than what many of the later studies I'm going to show were doing. Throughout the late 70s and 80s, there was an attempt to determine the effectiveness of IV antibiotics as more pharmaceutical companies were bringing up these options. And they found that in an actual randomized trial with the oral antibiotics, in addition to the mechanical bowel prep, they had to stop it early as there was such a marked improvement with the erythromycin down to 6% for these wound infections compared to the 30%. Moving into the 80s, and this is one of the first laptops, like a travel computer. I thought this was really pretty amazing. It was from 1983, that same year. They demonstrated the addition of IV antibiotics to oral neomycin had no benefit. So the patients that got bowel prep and neomycin had the same risk as those who had IV antibiotics. Although that hasn't been supported through the years, it really does kind of talk about the role of the oral antibiotics in reducing that flora and reducing wound infections. And this is going to be a theme really just repeated over and over throughout my little talk here. Through the 90s, there was a multiplicity of studies, and basically they were looking at what the best IV antibiotics were. And Dr. Rothenberger and colleagues here reported that a survey of the American the Colorectal Surgery Society, 92% of surgeons at that time were using IV and oral antibiotics as well. So in 2000, there was more double-blinded randomized trials comparing oral antibiotics with different IV versus IV alone. And again, their rates were from 16% with these newer IV antibiotics, but still 4.5% when they used the neomycin and metronidazole. moving on to the later 2000s, this is where the trend started moving away from the oral antibiotics, and studies were really looking more at the efficacy of IV antibiotics as solo therapy and comparing ertapenem, which ended up being the standard for the skip measures in some cases, that had a 15% 17% infectious complication compared to cefotetan at 26%. And this was where we started to trend towards using IV antibiotics alone. When Jung published the series that someone indicated that mechanical bowel prep did not add to the IV alone for swinging the pendulum in the other direction. At that point in 2010, so 20 years later, only 36% of surgeons were using the oral antibiotics in prep, indicating over that 20 years there was a shift towards just using the IV antibiotics alone. And clearly this was easier on the patients not to have to do a prep and not to have to take these antibiotics. But it really turns out to be at a significant postoperative expense for them. In 2010, we had this is when the trend started to swing back in the other direction, and there's these retrospective studies looking at these databases through Michigan, and they could see that their patients that had received the oral antibiotics along with mechanical bowel preparation really did have a reduced wound infection rate. Now, these are retrospective and has that limited component of the data, but over and over again, we see that those that received oral antibiotics along with the mechanical bowel preparation really did better. And there were several randomized controlled trials that indicated and confirmed this with different levels of data. Bellows reported a meta-analysis of 16 randomized trials where they used the 3 combined therapies and again had a significant reduction. Despite all this, in 2011, there was this Cochrane review, and I remember reviewing this as a fellow, and this, when you looked at this more closely, you can see that there really was no mention of oral antibiotics during this time frame, and these studies included may or may not have had oral antibiotics, but it wasn't clearly delineated. But you can see that there was similar anastomotic leak rates in that sort of 8 to 10 range. Similar, that's for the low anterior as well as colon surgery, around 3%, and wound infections were in that 8 to 9%. So the conclusion of this was it was safe to omit any sort of bowel prep, and you can just give IV antibiotics alone, and you'll have a similar outcome. But again, they really didn't include that oral antibiotics, and that has a significant impact. So just kind of reviewing what we've talked about so far, and these different studies up to about 2010, there's, with the oral antibiotics and mechanical bowel prep and IV antibiotics, you have around 5 to 9%, whereas with IV and mechanical bowel prep, it's in the 11 to 18 range, and with IV alone, that's around 8 to 17% of infectious patients have infectious complications. More recently, there's been use of the American College of Surgeons database in looking at retrospective studies, and there's really a flurry of studies, and depending on which populations you're looking at, whether it's colon or rectal, there's a little bit different variability, but the vast majority of them show a superiority with the addition of oral antibiotics to a mechanical bowel prep over no preparation alone. Just looking at this data and the quality of the data, and I think this is why some people kind of have a when you look, there's these editorials on, are we jumping conclusions or is this data real? There are some limitations to this data, meaning that they're retrospective, that in these cohorts, those that had the mechanical bowel preparation were a little bit healthier, where there was more sepsis in those that urgent surgeries, et cetera. And also in these retrospective reviews, it's an intent for bowel prep rather than what's really given. So there are some limitations to that. They do, however, measure some important things, including the specific types of infections, leak and ileus, as well as Clostridium difficile, which had been one of the things raised as perhaps we're changing that microflora and increasing our risk of C. difficile. So that will be, we'll look at a little bit more closely in the data that I'm going to present here. So one of the most recent ones that I could find was just out of a recent 2018 report where they had almost 6,000 patients in various combinations of PrEPs. But looking at the distribution here, we're back up to about 50% of the patients are getting the combined, like all three things. All these patients got IV antibiotics, whereas 30% just got the bowel prep alone, and about 20% had no preparation other than the pre-op antibiotics. And if you look at this, you'd see that there is a odds ratio favoring the three kinds of therapy: the mechanical bowel prep, the oral antibiotics, and IV, with an odds ratio of 0.5 essentially. With left-sided colectomy as an example, even open left-sided colectomy, which you'd think it would be at high risk, these were also improved. Anastomotic leak rates were favored a combined therapy at 0.4 with both laparoscopic and open, and they did not find any increased risk of C. difficile in these patients. So I took these are the images from that same study, and I took the liberty of drawing a green line at 5% because you can see that the percentage and scales are not identical here, with open colectomy being on the left and laparoscopic here on the right. And these different types of things. So the darkest column there is the no prep at all versus the mechanical bowel prep without antibiotics without prep, and then this column which consistently shows the lowest risks in surgical site infections as well as anastomotic leak are those that have all three of that. This is, again, the NSQIP data with those limitations I mentioned. Some other ways they looked at this, they found no superiority to giving the mechanical bowel prep without antibiotics on surgical site infections. And they found that if you couldn't give a mechanical bowel prep, but you did give oral antibiotics, you were better. So even if perhaps these patients can't tolerate a full bowel prep, maybe there is some benefit to giving the oral antibiotics. That sometimes it's kind of hard to add that up unless it's really just affecting the microbiome at the level of the mucosa. So more what we might think of as better quality data, these randomized controlled trials showed a benefit of mechanical bowel prep plus the oral antibiotics again, which reduced surgical site infections in this study of elective cases. And they found that the surgical site infections overall were lowered from that 16 to 7%, with incisional and wound infection rates down to less than 5% with this combined therapy. So, and this was a recent 2016 study that showed a similar benefit. And in this study, they looked at C. difficile again and did not show any increased risk of C. difficile with the additional antibiotics. This study is a randomized controlled trial looking at a broad spectrum of colon cases. So it includes those clean, contaminated, and dirty cases. And again, even with this more likely for infectious complications, their rate was 8% with the mechanical bowel prep, oral antibiotics, and IV. They showed similar extra-abdominal complications, similar postoperative ileus, so it didn't increase their ileus as one might expect. And they found that multivariable analysis showed that blood loss and ASA were independent effectors of surgical site infection towards the negative, but preoperative oral antibiotics had a dramatic improvement with an odds ratio of 0.2 for recommending that in this randomized controlled trial. So I just chose this as an example of the different published studies out there, and this was published just in June, and it showed a relative risk reduction for those with the oral IV and the mechanical bowel prep with an odds ratio of 0.5. So in summary, our patients are placed at high risk for surgical site infections and other infectious complications, and these risks can be reduced by the addition of oral antibiotics to mechanical bowel prep the day before surgery. Despite this, what appears to be quite a dramatic reduction in these. And sort of what we touched on earlier, leaks can have a negative impact both in the short-term morbidity, but long-term, I think it's, in my mind, there's not a lot of downside to this. And although the data might be not as pristine as some people might like, it still would be favorable. There are some other ongoing studies that are listed from the critics of this data, but in our practice, we've swung back towards the use of the oral antibiotics as well as mechanical bowel preparation and IV antibiotics for the 24 hours surrounding surgery. Thanks.
The question was, is there a mixture of antibiotics and PrEP altogether?
I haven't seen that, where you'd mix a liquid antibiotic into the preparation. It might be easier for the patients to take. As a person who takes calls from patients all the time, I haven't really seen a dramatic increase in folks having trouble with the bowel preps for surgery compared to those bowel preps we do for colonoscopies. So I think I would strongly talk a patient into taking them based on this review of this data.
The question was, any evidence of probiotic effect on perioperative leaks?
It's an interesting question. I don't have that specific data at the top of my head, but it would be worth looking at.
And the question was difference in outcomes between the non-PrEP and now the PrEP with antibiotics.
I would really say that our expectations have gotten higher. So what you thought of was acceptable before in terms of a wound infection rate or comparing antibiotics or no antibiotics, we used to quote a wound infection rate of 10 or 15%. I think with really more focusing on quality measures and really advocating for our patients, that holding ourselves to a higher standard, I think has really brought that back.
Question, should cases be canceled if a patient has not taken their bowel prep?
I would probably not go to that extent. You'd have to see why you're doing it. If it was purely elective, I think you would use that on a case-by-case basis. I think with the literature out there, it's not as if it's malpractice or what have you not to do it, but that would be a discussion with your patient perhaps that you are at increased risk and we haven't achieved all the modifiable components to that. But I wouldn't necessarily just flat out cancel a patient. I might more speak with them why they wouldn't have followed the instructions.
Thank you, Dr. Grahn.